Dear audience, it's my pleasure to be with you. I'm Dr. Elias Jarede from Lebanon, and it's my pleasure to be attending and presenting during the Brazilian Islamic Society. It's a web meeting, but still giving me an enormous pleasure to be with you. Well, this topic is about the keratoconus, when, what, and how to do. Just an overview of how we approach keratoconus, putting an algorithm, understanding the different modality of the treatment of keratoconus, understanding the patient need and the behavior of keratoconus, putting all together to know when and how to approach the keratoconus for management. Interventional procedures, cross-linking, PRK ring, fake IOL, corneal graft, how to use them and how to combine all of them to obtain the good outcome in keratoconus management. For this purpose, we divide the keratoconus into three categories according to the age. The conventional keratoconus from puberty up to the age of 35, 40, or 50 sometimes. The pediatric less than 14 years of age. Elderly or older keratoconus according it's for the time of cataract procedures. While understanding the algorithm how to approach keratoconus, definitely keratoconus are divided into mild, moderate versus advanced stage. And those mild, moderate, we are classifying them to low refractive power, moderate refractive power, good and corrected visual acuity versus poor corrected visual acuity. The same for the advanced keratoconus are divided into good corrected visual acuity versus bad corrected visual acuity. In all case of bad corrected visual acuity, we have to insert ring in the low refractive power ring allow maybe enough for to correct irregularities and as well refractive outcome. In the higher refractive power group, ring, probably one ring is to correct irregularities, and then we have visual rehabilitation by using the ICL or eyeglasses. Again, almost all patients in the young category, they undergo cross-linking with or without evidence of progression of keratoconus. In the elderly form, like 40 above, we treat with keratoconus only for those who demonstrate sign of progression. Again, we have published about the PRK after ICL in very few cases, and the LASIK extra as well. While the cross-linking is to stiffen the cornea, as I have mentioned, is performed almost in all young patients with or without evidence of progression because they are high risk for progression. And in the elder patient, we treat only those who demonstrate a sign of progression. How we do it in brief, mostly we do the conventional, or sometimes we do the pocket cross-linking using the anti-lace to create a pocket. We have done this in 2007 onward and using the regular cross-linking using the spiral technique with a reverse cut hinge ratio to create a pocket with an entrance, then dissecting and performing the injecting the riboflavin and exposing the cornea to UV light. Here we're showing the video how we do the cross-linking. In brief, spiral technique with a hinge, large hinge, only small cut, dissecting the pocket, and then after dissecting it, we inject riboflavin so the upper part of the lamella is not cut and is maintaining its biomechanical stability. Here using the 23 gauge cannula to be used to inject the riboflavin into the pocket and then doing the UV light exposure. Definitely has a quite good advantage keeping the epithelium intact, much less complication, risk of complication, and rapid visual rehabilitation after cross-linking. Here showing a case of pocket cross-linking with delineation of the pocket that we prepare the patient for ICL and keratoconus. Another cross-linking we use it is doing in thin cornea. Sometimes thin cornea, advanced keratoconus, we have no other alternative but to do cross-linking because of high vascularization of the cornea, which making the graft very risky. In such case, we remove epithelium and then we do soft contact lens to artificially enhance the corneal thickness and protecting the endothelium for any possible damage from the UV light exposure. As you can see here, the highly vascularized cornea and bleeding while removing the epithelium. Again, in thin cornea, most of the thin cornea, and this is our standard in doing the cross-linking, We are using the hypertonic sterile water to enhance the thickness of the cornea at the end of the riboflavin application. Our experience demonstrates that the riboflavin application thin the cornea quite a lot, is very dehydrating process. We have to enhance the thickness by using hypertonic sterile water. The question, does the hypertonic sterile water wash out the riboflavin and decrease the effectiveness of the cross-linking? Answer is no, because our rate of recurrence is very, very low compared to the international published one. We have only like 3.1 recurrence rate over 5 years after cross-linking. Well, again, in the cross-linking and ectasia, we have demonstrated that this is ongoing study to be published soon in the Journal of European Journal of Ophthalmology. We have like 22% recurrence rate in ectasia patient post-LASIK after doing the cross-linking. That implies to do another technique by inducing fibrogenesis vertically by puncturing the cornea and vertically to induce fibrosis, and this would help to reintegrate, biomechanically reintegrate the cornea to the underneath stroma and restore the corneal biomechanics. That's quite effective technique. Here in the left side video showing that using the blade, microblade, the diamond blade to do the puncturing. On the left side, we can use as well a bended needle at the desired depth, which is around 350 to 400 micron. It depends on the peripheral thickness of the cornea. I bend the needle, then I do the puncturing. We can do it simultaneously with the ring refraction, with the ring augmentation. That yielded very good result and stability of the cornea, sometimes extra flattening. Here we can show the instrumentation are very simple, and we can use direct visualization of the cornea to do more punching at the area of ectasia. Corneal OCT showing direct fibrous band created by the puncturing, reintegrating the flap, the previously left flap to the underneath stroma, and that would have helped to reintegrate the corneal biomechanical stability. Again, we do some cross-linking under the flap in case of early ectasia or early keratoconus with hyperopic shift and enough stromal thickness. Using the antralase in case of early keratoconus with hyperopic shift, hyperopic refraction, we do the antralase with 90 micron cut. That would imply cutting around only 40 microns of stroma, and the rest they account for the epithelium. And that would be pretty much equivalent to ablating around 3 diopters in myopia combined with cross-linking of the keratoconus. So the idea is that we are not damaging the cornea much in early keratoconus, but we are providing a very good stability, a very good refractive outcome in early keratoconus with hyperopic shift and wish the patient to be free of eyeglasses. The same for the ring. Understanding the ring effect is very important, how it does behave for the cornea. We have published about this in the mathematical analysis of corneal remodeling after ring implantation in keratoconus. While all our understanding is based on the concept of the conic section and the shape of the tunnel produced by this cut there. So cone, keratocone is pretty much equivalent to an oblique cone. When it's cut by a perpendicular cut to the cornea, it creates an elliptical shape and not a circular shape. That will conclude that the shape of the tunnel produced when we are cutting the cornea in keratoconus is not a sphere, but is an elliptical shape. One part of the ellipse is steep, the other part is flat. Understanding very well this effect would imply that when we are inserting the ring in the steep part, that will do centrifugal effect to flatten the cornea and obtain the desired effect. Once it's inserted in the flat parts, that would be the reverse effect and would push the cornea to the center and induce more irregularities. That's why we can explain in some cases when we explanted the upper part of the ring, in some cases of keratoconus, we got a better refractive outcome. So this ring, this understanding, we call the topography guided nomogram, would imply that the ring should be planted always under the steep cornea in keratoconus, regardless of the astigmatic axis. So topography guided nomogram, we choose the steep area where we have to implant the ring. Again, 1 or 2 rings, that depends on the refractive power and the amount of the irregularities to be corrected. Here is a patient with bilateral keratoconus in the right eye, pretty much similar to the left eye, but with low refractive power. We inserted only 1 ring inferiorly. In the right eye, we have high refractive error. So that's why one thick anterior, one thin superior. So in this one, we call it topography guided mammogram. We have to set our incision in order to put the thick ring under the steep area, regardless of the axis of astigmatism. And again, the shape of the ring has to be determined according to the amount of irregularities. Here we can see that our plan to put 210 degrees because in the pellicule light we have large amount of ectasia in the cornea. We use topography, direct visualization, because it's topography guided mammogram. We do direct visualization to put the ring underneath the steep area of the cone, or sometimes, as showing here, another technique we have used is to print the topography in a plastic sheet, transfer the plastic sheet, and we put the transparent plastic sheet overlaying the microscope screen as shown on the TV, and then I start inserting this ring in order to fit exactly the steep area of the corner that is shown in the transparent paper. Moreover, we have done biologic ring using a donor cornea to fashion a ring at desired cut, usually used an internal 8 and external 9 millimeter, or internal 7.5 and external 8.5 millimeter. Before inserting, we insert this to replace the PMMA that has induced a melting. So we have to make sure that before inserting, we have to remove the epithelium and endothelium at the same time, and this part is soaked with alcohol and as well soaked with fortified antibiotic each for 1 minute. Here's showing the different technique, and here's showing as well how the biologic effect is pretty much similar to the PMMA effect that produces the internal bulging and the flattening effect. In most cases, we have implanted, we save the effect of the ring that's been induced by the PMMA and then replaced by the biologic one. Regarding the visual rehabilitation as well, we have used the ICL, our favorite one in keratoconus. Definitely the ectasia, the keratoconus has to show enough evidence of stability. Again, we stabilize all corner by cross-linking of young patients with or without evidence of regression. Elderly, like 35, 40 and above, if they have long time history of stable keratoconus, we dare not to do the cross-linking. It's quite an effective and safe procedure as showing published result. The same we have done in toric ICL after ring implantation. We have published in the same in corneal irregularities, low correct distance visual acuity. We do implant the ring in order to treat irregularities, enhance vision, corrected vision, and then do the ICL implantation. Regarding the PRK, photorefractive keratectomy, our method is the non-topo guided because we believe that in case of irregularities of keratoconus should not be treated by laser because it's an ablative procedure. We get lots of tissue loss, and we have enough experience with the ring to use it in order to treat the irregularities. So the non-topo guided is tissue saving and more predictive outcome. As well, we have used the laser post-ring implantation in keratoconus with some residual low refractive error, myopic refractive error, with the desire of patient to be totally free of eyeglasses and attain very good and corrected visual acuity. Again, is non-topo guided using a modified parameter, mainly a small optical zone, and always we use the manifest refraction, and we try to manipulate the ratio of sphere equivalent to the astigmatism. Well, if I can replace the astigmatism by sphere in order to obtain the same vision, I would go for the sphere because for each 2 diopter of astigmatism, there is 1 diopter of sphere, and that would lead to less amount of maximum myopic ablation in the center. Regarding the second category of keratoconus in pediatric, we take it within 14 years of age. Worth mentioning that the major risk factor are allergy and family history. Again, published mammogram for the same topic in Journal of Refractive Surgery. So while we have to mention that the spectacle-free of life, of spectacle-free style of life is not an option in pediatrics because it's not a stable refraction. But however, we can still using the visual rehabilitation, mainly the ICL, to target severe anisotropia because at this group of age they need binocularity is very essential for their development, for the development and psychological development and visual rehabilitation. So in some cases, we use the ICL to treat only anisotropy. Otherwise, ring to treat irregularities and cross-linking to stabilize the eye and eyeglasses. Well, the question would be, ring safe to treat irregularities in the pediatric? Our answer, our experience would say yes. We have enough experience in ring and keratoconus. Mostly are done the same like in adults under topical anesthesia, quite tolerant patient. Even they behave better than others in ring augmentation. Attained on all patients who never failed it. Definitely this has to be done in the hand of experienced surgeon. Less trauma, fast, and reassuring the patient, giving the patient trust is very essential element. Here shown 9-year-old patient after ring augmentation under topical anesthesia in the right arm. Well, in the elderly group, how we approach mainly at the time of cataract, worth mentioning in our nomogram that has been published as well, that only eyes with good corrected distance, with good corrected visual acuity by history, and astigmatic axis which coincide with the topographic axis should be implanted with toric IOL. So again, if we have a refractive axis of astigmatism that coincide with the topographic axis. And this refractive axis of astigmatism can be attained either by history, can be retrieved by history or from the eyeglass of the patient, because at the time of the cataract probably it's hard to get a good refraction. Anyway, refractive astigmatism should coincide with the topographic astigmatism. Then we go with the toric IOL. Definitely we have to manipulate the magnitude of astigmatism and go with probably with the refractive magnitude rather than with the topographic magnitude or something in between. Eyes with poor corrected distance visual acuity should be implanted always with the ring to regularize the ocular surface, and then do mostly monofocal IOL. And then visual rehabilitation after the monofocal IOL can be attained by the ICL, which we have a good experience in implanting ICL in cerebral patient. Sometimes, very rare cases, we have implanted toric IOL after ring implantation, where we have been sure that the topographic axis of astigmatism is exactly the axis of refractive astigmatism. He's showing cases of keratoconus, peripseudo-like keratoconus, where the refractive astigmatism coincides with the corneal astigmatism. Here as well, showing a technique as well using hard contact lens in keratoconus doing the cataract, showing the anterior capsule, which is irregular because of the corneal irregularities. Once fitting a hard contact lens, which is customized manually to fit the main incision of the surgeon using the microthread. Here the anterior capsule after fitting the hard contact lens is quite regular regarding to the one without hard contact lens. Here showing how we fit the hard contact lens using viscoelastic. Visibility of the anterior chamber and anterior chamber structure are quite good, and then we can perform very controlled phaco emulsification without complication, mainly when we reach the posterior capsule, because we have experience of posterior capsule rupture and highly distorted cornea. Worth mentioning, like all steps of the phaco can be attained without any problem, and the incision side, they are quite controlled within the notch of the hard contact lens, which was manually drilled to create these notches. Thank you very much.